So hi, I think most of you know me. If there are a few interns and don't, my name is Gunjan and I work with the section of general medicine. And today we'll be talking about patient safety. And one reason why I chose to talk about this subject is because every single person that I mentioned this to, when I told them I was going to talk about patient safety, responded with oh no, do you have to? So I responded by saying, yes, we have to. Incidentally, I have no conflict of interest since I doubt it's a multi-million-dollar company out there. So let's start. I always like polling people with things. So if you haven't picked up a clicker, you can come down here or pick one up or I'll pass one to you. But how important, if you had to rank the causes of death from 1 to 10, where would you rank medical errors? I don't have one in there because that's coronary heart disease. We'll just put that in there. Just, HIV, diabetes, motor vehicle accidents. Think of all of those things and think where, if you had to rank them, where would you rank medical errors? And I don't know how many people we have in the room. I've got about 20 responses. Suddenly I have 29. So let's see what you all say. And we're kind of all over the place. But the majority of you, and I think that is probably our students who had a similar session with me at the start of junior orientation and were told that medical errors are actually accounting as the third leading cause of death in today's statistics. It has outpaced stroke, it has outpaced COPD in respiratory diseases, and is now preceded only by heart disease and cancer. And third on the list, as we talked about, is medical errors. And this was the first report that the IOM published. The Institute of Medicine published this report in 1999. And at that time, they said, low estimate about 40,000 people, high estimate close to 100,000 people are dying every year because of medical errors. And they said, most of it is medical errors, quite a few are surgical errors. And at that time, depending upon where you placed it, with the low or the high, it would account for the fourth or the sixth leading cause of death. And they pointed out that deaths from adverse events were greater than the combined mortality from HIV, plus the Afghan war, plus motor vehicle accidents, plus drug injuries. Deaths caused by us far outweigh any of those. And that, so one of the things that I was doing with this is trying to use medical errors almost like a disease. And even when given numbers like 400,000 people, it's hard to estimate exactly how many patients that means. So we talk about case fatality rates and ratios. So the IGO office actually calculated the rate of harm. And what they came back at is they looked at the population of Medicare patients. This was 2010. And they say that 27% of these patients had some kind of error. And about half of those had an error that resulted in bad outcomes, permanent harm, death, some problem. And this is the more recent article. It has been the source of a lot of controversy since it came out. This was 2013. This is Dr. John James. He works with the NASA. I'll talk more about that. But he basically came out and said that there are 2 million serious adverse events every year. And per his estimation, between 200,000 to 400,000 people die every year because of what we do. And thus, it is now the third leading cause of death after heart disease and cancer. And most of this, by the way, is in hospitalized data. The problem is we don't even know the numbers for outpatient medicine. And it's not insignificant. I can just say that. And the estimated cost to the healthcare system is about $1 trillion per year. And you've all seen the numbers that the American healthcare system is widely recognized to be the world's most expensive and least efficient healthcare system. And these costs are probably one of the reasons why the amount of money spent in America is greater than the sum total of the next 10 countries. We spend more probably because of costs like this. So at the end of the day, the IOM had a follow-up report which basically said, this is not right. the healthcare that the public deserves and the healthcare that they are getting, there's a big gap in here, a gap wide enough that they called it a chasm, not just a gap. And they took out another report that said, how do we cross it? So anytime we have information like that out in the data, it's the Times reported it, The Economist reported it, all of these magazines reported it. It starts a conversation, which is always a good thing to do. Sometimes we're confused like these guys. Sometimes we take something out of it. And certainly the conversation started. If you look at the number of publications before and after the IOM report, there was a significant rise in people that were now interested in patient safety. And we're talking about it. But if you look at it carefully, most of them were comments. People like me just saying, oh, this is bad. Very little original studies on what can we do to change this. And of course, we had to respond to it. And a lot of physicians came out basically saying, oh, we don't believe it. And that, we've got cancer physicians in here. Maybe that was, it's a defense mechanism. Denial is the first form, after all, before we could accept it. And this was always interesting because this was published in JAMA just a few months after the IOM. And they basically said, you know what? We looked at this, and most of these people would have only lived for about 3 months. Anyway. So, yeah, it's not that big a deal, which is not really the question at hand. The question is not really, we never entered the business of playing God and playing who should live and who shouldn't live. The question is, did they deserve to die today from a medical error or not? That was the only question. But again, we had lots of responses to this. And the NEJM, as always, the New England Journal of Medicine, decided, let's just ask physicians, what do they think? So they basically found a population of people, patients and doctors, and asked them this simple question that I'm now asking you. If you don't have a clicker, I'll pass them around to you. But respond that for me is, how many of you have had somebody who has had somebody have an error? Anybody? And you guys can keep checking and stuff, and we'll see. Since we've got such a controversy about what that real number is, let's try to see what kind of numbers we get. And I've got about 35, 36 responses, so I'm going to continue. And yes is 46%. Well, that's almost half of us. And if you think about the number of people that enter the healthcare system every day, then even Dr. John James' numbers are probably underestimating what we're seeing. In the NEJM article, actually, the number reported by both doctors and patients was surprisingly equal. About a third of them, I think 38% of physicians and about 35% of patients said, we know somebody who's had something happen to them. But what was really interesting was, while they both had had the same experiences, their viewpoints were very different. The patients, for example, strongly believed that if we suspend the license of these doctors, it's going to make a difference. Only about 3% of the doctors believed that. The patients also believed that the hospitals should be reporting all of these things. And 3/4 of them thought that's going to be very effective. Only about a quarter of the doctors thought that would be effective. Less than a quarter of the doctors thought that encouraging voluntarily, not mandatory, not CMS saying hospitals need to send us this data, but voluntarily saying, hey, we noticed this, would make a difference. If you look at it, the most interesting part was 86% of physicians definitely believe that we should not release this data, that it has to be confidential, while the population believed that this information was shared public property and needed to be told. I wish those authors had asked the doctors what they thought would work, since on all of the options that the writers gave, the physicians were saying, oh, that won't work, and that won't work, and that won't work. The question is, what would? And, I talked about Dr. John James earlier. He's the NASA scientist. And the answer to why we need to ask that question, what would work, is because of people like him. And as I said, it is very controversial. Dr. James had a son of 19 years old who died as a result of what he believes was careless health care. The boy had a prolonged QT, was never told he couldn't be a competitive runner, and thus something bad happened. But Dr. J, he went ahead to put up a website. He started this nonprofit organization called Patient Safety America, which is asking people, telling people what questions to ask their doctors so that we can avoid further injury like this. And we talk about this. I know my colleagues agree with me. I tell the students every time, the best reason for doing this job is the people we serve, the patients we meet, the way they respond to things. It's inspiring, it's humbling. And these are sites that patients set up. This family had an 18-month-old child who died because a nurse and a doctor mistakenly ordered methadone to a baby, and she's dead. And they have now partnered with Duke. I mean, when I think of the things I would do to somebody that harmed my family, which are quite a few, spending the rest of my life trying to earn money from them, trying to help them is not on the list of things that I would do. But that is what these families have done. People that have lost children have spent their entire lifetime, fundraising for those same institutions and saying, here are $5 million, start a patient safety prevention program. The study with Duke it's a beautiful module. I think I have a reference at the end. It's open access. Anybody can read it and learn about patient safety. And they did it from a family. So that is the reason to me why we need to ask these questions. And a lot of people ask these questions, not to mention the regulatory authorities. So we developed all of these national patient safety goals. The JCO started. You want to think of a world where money doesn't complicate things, but that doesn't really exist. So for a lot of these things, money was a factor. Medicare came back and said, a hospital can be careless, a patient can fall down, sustain a hip fracture, and the hospital will make more money. And payers were asking, where is that fair? Why is it fair? What is the incentive for a hospital to be more careful about their patients? So they put up all of these things and started having all of these CMS reporting ideas. And if you look at them, these are the 2015 National Safety Goals. There's nothing wrong with them. And I admit this because Elizabeth's not here, but I'm guilty of sitting across from her in lots of quality council meetings and rolling my eyes when she said it was a CMS requirement for something. And I was like, oh God, that's a dirty word. Or JCO wanted me to do this. But if you look at it, none of this is bad. I mean, what about it doesn't make sense? That we should have alarms that actually ring. The FDA changed their guideline just last year because about 100 people died last year simply because their device alarm didn't ring or the nurse had turned it down and people died. That's a stupid reason to die, right? So they put that out there and said, try to reduce these risks. And while nothing in that is bad, what they don't tell us is, that's great, let's do this. What we don't know is how do we do it? How do we cross that chasm of quality? And this is what the IOM said. They said healthcare should be safe, it should be effective, which is what Dr. John James said is my son was not given care based on clinical guidelines. My son had long QT syndrome. Why did the doctor do a heart cath and then rupture his ventricle and cause my 19-year-old child to die? That is not what the recommended outcome is. They say it should be patient-centered, it should be timely, it should be efficient, and it should be equitable. Everybody should get the same care. And while these are wonderful qualities, they're very hard, and they're not, for someone that works in both the clinic and the hospital, they're often competitive. I work with our nurses, and they'll be like, Doc, we got to improve throughput. We got to get patients in and out in 20 minutes. And I get it has to be timely. But all of the medicine residents that were in Morning Report today and had the patient that had gone to the urgent care and was surely treated in a timely fashion, but treated wrongly, is again not safe care. So there is a balance, and what nobody told us is how to achieve that balance. So, as I told you before, I thought when I was dealing with this is, I don't know how to do this. And it was taken over by all of these regulatory agencies and JCO telling me to do something and CMS reporting something. And I don't know about you, but it's kind of like when teenagers are told to do something because I told you so. It's kind of the reaction a lot of doctors get, which is why across the country there are reports, is why are physicians not buying in? When JCO is saying keep people safe, why are physicians digging their heels in? And part of that could be because We don't understand that psych. We don't. But what we do understand is diseases. So what I thought I would do is just take medical errors as a disease. So let's understand this disease. What's our pathophysiology? What's the substrate? Who does it affect? And there are quite a few studies. It's very interesting that geriatric patients, that Medicaid and Medicare patients have greater harm done to them than private pay patients. Now, I'm not suggesting that we're mean to our Medicaid, Medicare. Maybe those people are sicker to begin with. Certainly the older people are at higher risk of adverse outcomes. It's just something they've noticed. Patients with limited English proficiency, which makes sense. You know, in the IOM report, about 70% of errors occurred because of communication problems. I assumed you understood. You did not. I thought this is what you would do, and you were thinking of something else, and I never clarified it. But the bottom line is everybody. You know, we talk about, you know, the original slide said patients, you know, who do you blame? And certainly our patients probably don't understand, and, you know, they have limited English skills, they have limited education skills. But what all this research shows is that you can be the most intelligent person, a rocket scientist at NASA, and something bad can happen to you. Anybody can have this happen to you. We talk about the pathogen here. So the pathogen, I would say, would be a broken healthcare system. And there are so many studies on this. There are studies like burnt out doctors, the ones that make more mistakes. And just this month, there were 3 studies reported on the July effect. Are trainees responsible for bad healthcare? You know, it's a skill. Is the education system responsible? And at the end of the day, the best, most professional, most moral physician will make a mistake. That is the bottom line that we have to understand. Anybody involved in the healthcare field can make an error. And like with all diseases, the question we would ask is, what can we do to prevent this? And the bottom line is that it is preventable. 70% in all of the studies that they've looked at, up to 70% of all of these were preventable. We could stop them. All of those people could have lived. Only about a quarter of them were probably not something that we could do about. For most of them, we could have done something. So let's look at this. You know, we have, as I said, let's look at it like any other disease. I mean, how many hours do we spend teaching you guys about diabetes? Right down to the molecular level and the receptor level, right? Hours and hours and weeks in your curriculum devoted to single molecules. And those diseases are not even killing half as many people as medical errors are. So let's take a second, step back, and try to analyze errors. So when you look at errors, and there are different classifications. Simply speaking, they can be what we call skill-based errors. You know, you're just doing something at a skill level, you're used to it, you're driving, and you pass through a red light simply because you were texting your wife at the time, or somebody called you. It was a slip, it was a lapse, we just passed through it. They can be rule-based errors, where you don't know the rules. Maybe you come from a country where the red light meant go, and you actually didn't have the time to go look at the rules and look at that, and that's why you made an error. Or maybe you made an error because you didn't know something, knowledge-based errors, and that's where maybe you had to cross the red light when the light was off, and you didn't know how to deal with it. Like, what do I do now? Do I wait for that guy? Do I cross? That required conscious problem solving that you were incapable of doing. Either one of these can cause an error. Dr. Reason was the person that did a lot of research on this, and he basically called it the blunt end versus the sharp end. Traditionally, we focused on the sharp end. So I give a wrong injection today. I'm the sharp end. And most of the time, that's the easy one, right? Because I know she gave the wrong injection. Boom, that's my sharp end. What he talked about was there's a blunt end that's often not visible, that is also responsible for errors, and that is the system that we have to look at. And we talk about active errors again that are done by the user versus latent errors. And you guys have heard about the Swiss cheese phenomena. We talk about all these defenses, and we say that they've got holes in them. And part of these holes are just system-based holes. They're always there. And when they just seem to line up with the system-based hole plus my own deficiency, and they line up, and right away an error will occur. Just different ways of looking at how and why we make mistakes. But the bottom line is everybody can make a mistake. And generally, it is the result of circumstances beyond our control. And this is what I love it. It says systems that depend upon a perfect human being are inherently flawed. If that's what you're always looking at, is that the person operating will always be perfect and always at the top of his game with constant attention, well, that is not how we can keep our patients safe. That's too much to depend for. So, and there are lots of factors. I mean, you guys know about this. Fatigue, how much you slept, how many times your beeper rang while you were doing something. And all of these factors are known to contribute to errors. And again, this is out of the IOM report, and they say, depending on perfect human performance to ensure patient safety is scientifically and practically just not happening. It's unreliable because humans are going to make mistakes. So we begin with accepting that fact. And the IOM also admitted, they said, it's not that they're bad doctors, it's just medicine has changed so much. And I love that they put it in this, is that it's just so complex. If some of my physicians here that have been practicing for more than 20 years will tell you, there is so much more now to know, to do, to manage, to watch, to talk to arrange. I used to have an attending that used to say, Gunjan, it used to be so simple. And now there's a lot more. There's just so much that we all have to do. And the system was always catered to acute care issues and is crumbling under the weight of chronic illnesses that we are dealing with. So, where do we go from here? We said humans are capable of error, and we said we've got a tough job to do. So what does that mean? Does that mean we just accept the fact that 500,000 people every year will die because the system's bad and humans are prone to error and we don't know what to do? Go ahead.
What are we doing to kill these people?
Good.
I've never heard of giving a neonate morphine before. I mean, that's beyond. I've been here for 2-3 years. I can't think of one time where we had human error and somebody died.
Well, you can't think of one time, you cannot think of one time where an active error was committed in your presence, yet 46% of the people sitting here said they knew of an error committed to them or a loved family member.
I thought you said mortality was number.
It is, yeah. So the mortality rates are also high. So we can talk about that. The errors committed are not always an active thing. An error can also be an inaction. Failure to act in time, not diagnosing something in time. And I've got examples at the end which I'll talk about. But the answer is, are we the only industry that does something really complex and really complicated that is mitigated by human factors? And the answer is no. And that's where we look to. We look at other HRO organizations that work with high risk, high reliability. And the one example that we've always looked at is the aviation industry. What we're going through now is what the aviation industry went through in the 70s. At a time when they were scared that governmental regulations were going to totally change their life around because they were having so many accidents. And they had to step back, look at their culture, evaluate it, and see, what are we doing wrong? What can we do better? So we're not the only people that work in a situation where there's a lot of complexity, a lot of reliability, a lot of variability between patients, practitioners, conditions. Have you ever gone to Disney? Just seen the amount of people that those guys manage to take through every single thing and deliver without an accident? It is amazing what those organizations do. And this is how they are defined. Those guys are obsessed with failure. That is what they look at. They begin by thinking there's going to be a mistake. We're going to catch it. They're always looking out for it. Unlike us, where a mistake is treated as a cause, they treat a mistake as a consequence of everything that they didn't look at beforehand that they should have looked at. And again, it's a commitment that they present all across. So there are lots of ways that these guys have interventions, and we look at it. And interventions can be people-focused, and you notice they're at the, where is this thing you work? Yeah, they're at the bottom of our little hierarchy is people-focused. This is where we do, right? Anything goes wrong, and we'll say patient-educated, student-educated. The resident was told never to do this again, and God knows I yelled at him big enough, loud enough. The last level 4 I got, I was a patient that was very sick, was dying, and basically the NG tube dislodged in the middle of the night, and the patient became short of breath. The resident went down. heard the patient. He documented he heard crackles. He got an X-ray. He thought it was, full of fluid, and he said, let's give Lasix. And basically it took me, by the time I came on, that happened at 4 in the morning, I came on at like 8, then saw something else. Before I made the diagnosis, 5 hours had elapsed before I realized that the NG tube had moved, and all night long I was feeding his lung with tube feed going at 20 ml an hour. And obviously the patient died some 4 hours later. And when I got that level 4, that's where it ended, right? But that's the difference with these high-risk organizations, is that's where it starts for them, where it ends for me, where I just accepted it, went to my chair and said, hey, I already feel bad enough that this happened. Now the truth is, I don't know what I could have done to prevent it, but this is where it ends. I documented that I have been educated. I educated my residents. God knows I yelled at them. I cried with them. But this is where they say that's a low intent. That doesn't do much. It's at the bottom. What does better are when we change other things, when we make rules and policies, where we put a rule down that says a nurse will not even push back an NG without checking placement. There has to be a mandatory X-ray. That's where things would change, so another person would not have that same encounter. So that's where they'll look at. So what bottom line is, we looked at all of these and we made some changes. One of the big things was we looked at the Department of Defense with the Navy. Harvard had one really simple obstetric case of a 30-year-old woman that just walked in to deliver a baby, and 10 hours later, the baby was dead. She had a ruptured uterus, had to get a hysterectomy at the age of 30. And it turned out it was just communication failure between the attending, the resident, the anesthesiologist. So they felt terrible. They teamed up with the Department of Defense, and they did what we call crew resource management. This is where they work with, how do you work as a team? You might know everything yourself, but how do you work with other people? And we've had lots of studies with improvements with that. We've had checklists. In fact, I'm going to present our own data, but this was the original research from 2006, which showed that just having a checklist which looked at how we insert a central line and how we clean it will reduce our risk of central line associated bloodstream infections. We decided to do some innovative things. The problem is always in getting information. So ideally, if we're committed to improvement, then every one of us should feel like sending me every single error, even if it was not important or only slight or not big. And this group decided, let's just give our residents an iPad with a simple, interactive interface that they would, as part of their handoff, just write down if they had any errors. And they had tripled the error reporting that they did earlier. So all of these things improved somewhat. They did, this was another study reported in NEJM. They had like 15 medicine programs. And once they trained them how to give a proper handoff using the S-bar technique, they had a decline in adverse events. And most importantly, just putting an EMR, I think, was important enough in the errors it reduced. I was talking to a faculty member last week about my grand rounds, and she was like, you remember those paper prescriptions? She had a patient that showed up on Coumadin. She couldn't understand why the man was on Coumadin. He had no indication for it. And turns out the doctor had written for Cardiura. But the handwriting was so bad that multiple people continued, and the patient just took it, and this is where patient factors come in. He never questioned why I'm given a blood thinner, probably never read the description, and something bad could have happened. And I don't know if I should thank God or our organization, but I do thank somebody for Epic every day, because that is the single most, if we did one thing for patient safety, I would say it's Epic. Just having that computerized thing, and we've got things in there. It sends you a reminder, don't give in pregnancy, it's a Schedule X, it's a Schedule D. Think of a lactation, this is a drug disease interaction. And we've had multiple meta-analysis that show improvement with this. And not to forget, the stick probably does help. When hospitals are faced with the fact that they're going to lose accreditation, they scramble and they set up committees and say, let's do this, let's reduce our rates, because we got to report it to CMS, it's mandatory. So I do believe some effects happened with that. And of course, we taught people how to speak up, because this was the most interesting thing. When they looked at all of those accidents that were happening in the airline industry, they found that in 70% of the times, somebody else in the cockpit knew that something was wrong. But that somebody didn't necessarily feel empowered enough to change the outcome. So something bad would happen. And it's the same with medicine. So they've done studies on teaching nurses how to speak up to physicians, teaching medical students how to speak up to physicians. It's not easy, and they've done studies asking, why don't we speak up? What are we scared of? And a lot of it depends upon the culture, what we believe will be the impact of our speaking up. Will we get in trouble? I'm not going to speak up if I'm going to get in trouble, right? And things like that. So we've done studies on that and implemented these things. And how many years is it? 15 years after the IOM report, we've got our little report card, and we do show some improvement. Major reduction in the risk of central line associated bloodstream infections. Nearly half of them have been reduced across the country. Surgical site infections are less. Interestingly, catheter-associated UTIs are high, but almost everything, including C. diff and MRSA, acquired in the hospital are reduced. Now, of course, that resulted in less people dying. 50,000 people died less projected based upon what we did. And we believe that we saved about 12 billion just in 3 years by doing any or all of these interventions. And of course, with Louisiana, we always have to be a little more challenging. So we've had some improvements, but not as many. Our MRSA rates are actually 22%, so they went up while the rest of the country went down. Our CLABSIs went down by 31, the rest of the country went down by 46. But bottom line is we're making improvements too. And I asked Tina to send me information on how LSU is doing, and we've done pretty well too. Our CLABSI rates in like 2006 were, I think our SIR was like 4, it's down to 1.1 right now. Our UTI rate is lesser than that of the country. Our MRSA bacteremia, the SIR is still 1.4 across the country, it's 0.5, so we're still higher, but we do live in Louisiana. Our C. diff incidence rate is actually lower than that across the country. I don't know how much of that is due to our Xenex. Have you guys seen our Xenexes around? Those were our fancy little robots that would take the UV light technology and clean out a room of all spores and everything within like 10 minutes, better than a human could. So we've had some improvements, but interestingly, when I asked her to send me data from year-to-year comparison, she had to admit to me that our rates actually went up this year again. They're better than they were 5 years ago, but last year we were better than this. And that raises the question of, how do we sustain this? We make some inroads, Medicare starts saying, we're not going to pay you. Then we all get scared. We start doing something else better. We're more careful about pressure sores and things like that. But how do we continue on that thing of continued improvement? How do we not let these successes detract us? And that goes into the culture. This is what we call the knowing-doing gap. First is like, do we know what to do? And yeah, we know what to do. We know we have to wash our hands. Are we doing it? And this is what they call the knowing-doing gap. A lot of it has to do with the culture. A lot of it has to do with the system. If you go with the sharp end, then I'm at fault for not cleaning my hands. If you go with the blunt end, then you think about the fact that we have 2 patients in one room. Knowing that humans are likely to commit an error, would it make more sense to put that hand cleaning thing outside the room so that the physician has to remember to walk out, clean their hands, then walk back in? You know how many times I've been in a room and I finished seeing a patient and I'm walking out and the resident will be like, no, Dr. K, Ms. Jones is right next door, is right next to the bed. And I'm like, no, I'm going to clean my hands, and you should too. But that's where you're waiting for that perfect physician, right? For that perfect resident who will always remember, never mind that he's got 4 pages waiting. Yes, sir?
1/3 of the dispensers being emptied and given is not.
I agree with you, and that's again a systems issue. But again, and who was with me? Sarah was with me last month, and on one floor, it was funny because I went, pshk, okay, then when another pshk. I tried 4 dispensers before I found one that worked for me. But here's the question, how many of us stop our rounds, walk to the nurse, and say, hey, who's in charge of fixing these? And I'm not saying it's my fault or your fault, that's where this whole culture thing is coming up. We used the example of the disease earlier, right? We looked at medical errors like a disease, like what was the pathogenesis, what is the physiology? Well, let's take another disease. Let's take diabetes. We have a knowing-doing gap, right? We know all about diabetes. We know what patients have to do to fix their diabetes. Are they doing it? How many of the residents have seen patients? What do we call them? What is the word you guys use? Non-compliant. We're not supposed to say that, right? We're supposed to say non-adherent because compliant is rude. Well, we're the same. We're non-compliant. We know what we should be doing. Are we doing it? And if we're not, why aren't we? And this is where it all comes back to, is when we make a change, it all goes back to, why do we do what we do? Why do I walk away from a floor without telling the nurse that that dispenser needs to be fixed? Why do I get upset that I have to call the surgeon about something? You know, I've had people say, it's not my job. When you go with the culture of safety, everything to protect that patient is your job. Bottom line. Is it easy? No way. But nobody said this was an easy field. You have to do what you have to do. What's most interesting, a culture of an institution is often not based off their policies. Their policies might be really good, absolutely seeped in patient safety. A culture is made up of these stories, these beliefs that somehow just permeate everything. Like in the Department of Medicine, we talk all the time about there's no such thing as, what do we say, partial ACS. How many times have we had this conversation? All the attendings are on the same page that there is no such thing as partial ACS. Yet again and again, we see patients admitted for chest pain and not placed on any ACS stuff, right? And that's where the culture comes in. It's often made up of these weird beliefs, these weird stories that might have been percolating from we don't know where. Nobody can tell when it started. And it's often in conflict with what we believe. So the culture of safety is the concept that they're really trying to push. And the CDC basically defines it as a shared commitment to ensure that we have a safe working place for our patients and our employees. I mean, I didn't talk about this earlier, but we're also the consumers of our own healthcare system, right? I have to bring my son to this hospital, to any hospital, to the healthcare system. It's to my advantage if it's a safer healthcare system. And the characteristics is, the first thing they say is it's got to be an environment where anybody can speak up to anybody. A freshman medical student can question me and say, Dr. K, you did not clean your hands properly. You know, you rubbed the sanitizer like this, you forgot the back of your hands. Why don't you do that? It should be where people are not scared about reporting close calls, and it has to be easy. I mean, I'm guilty of this. We were on last month, and we had somebody that the nurse didn't start a diet on. I know who my resident was. The resident had ordered the diet in the middle of and he called in the evening and said, please start it. He came in the next morning at 8 o'clock. He had to go hunt the nurse and say, why haven't you initiated the tube feeds? Did I write it up? No, I didn't. Why? Because, you know, I had 5 more meetings that day and I had to teach and I don't even know where to find that form. So when you actually embrace the culture, you make it easy. You make it a one-click process for somebody to send the information to. One of the best things we did recently is we started our outpatient pharmacy. And I can't tell you how many times it is that as I'm crossing that window, Judy will stop me, Judy Platt or Lawrence will stop me and say, hey, can you just, the script doesn't make sense. You know, one of the residents was asking what kind of errors we have. If I could tell you what I do on a monthly basis and how many scripts I change, that if I hadn't, would have resulted in terrible outcomes. How many times Dr. Anderson has called me and said, I've tried paging this resident 6 times. This patient is out of insulin for 2 days. He's going to get admitted with DKA. That is an error. That is our fault. We need to fix the system. But the advantage of a system like that is everybody is accountable. Everybody is answerable to the youngest person, the bottommost person on that run. There is no hierarchy. And this is the AHRQ website, and I do encourage you to go to it, as well as the JACO website. And one of the simplest things they said is that before we do anything, let's assess our culture. What kind of culture do we have? So they set up this survey where they ask people, so hospitals can sign up, you can sign up. It's a free PDF, and you can see how you pass on this. And they ask questions like, we're actively doing things to improve patient safety, and it's a Likert scale. You have to say you strongly agree, disagree, strongly disagree. It's a 1 on 5 scale. And they ask questions like, mistakes lead to positive changes. When an event is reported, we feel like the problem is being fixed, or we feel like the person is being, channeled here. They ask questions like, we are always in crisis mode, we are always trying to do too much, or I'm scared that the mistake I make is going to be kept in my personal file. Like, I genuinely have no idea where my level 4s have gone. Or our procedures are good at preventing errors. We spend a lot of time figuring out why the error occurred. What were the, what was happening? Why did that happen? Versus just the fact that we made a mistake. So they ask people these kind of questions. And I didn't have the time to make all of you do that, but I did think I would ask you guys, just do a survey of what kind of culture do you think we have? Do you think we focus on the blunt end? We focus on the why did this happen? Or do we focus on what was wrong with this resident that he forgot to do this? What kind of culture do you guys think we have at LSU? And this is why I use the clickers, because keeping things anonymous often brings out honest responses from people, because I have no way of knowing how you polled. So I've got about 30 people here. So I'm going to go ahead. And that's worse than I thought. But that also tells us that this is where we need to start working. If we're going to make a difference, this is how we have to start. We got to change that culture. We got to change the stories and maybe our policies. I mean, I'm currently working on a sepsis program. I'm currently working on a falls prevention program. I had my interns go to the meeting and they were really good. We've got a medication safety intervention going on. We are actively doing things for patient safety in this institute, yet all of us believe we're not. And this is what they've noticed in a bunch of places, is we seem to have a culture that is not congruent with what we actually want. So the patient safety culture, again, we talked about, is where an error is seen as a consequence. It's not the cause. At all times, you do an active root cause analysis. The one time I was at M&M last year, I insisted on drawing a fishbone as to why we made that mistake. Because that is what, if you really want to investigate this, then that's where it starts. It doesn't end with we've isolated this person. That's where it begins, and that's where you take it forward. We just had one incident recently. I was very impressed with this resident. This was somebody that went to the endoscopy lab, was supposed to have a procedure done for varices, inject a sclerosant in it. And the resident documented in his chart that he was in the ER, and the nurse said, hey, what do I do with this shot? And the doctor said, the resident said, I don't know. I'm not aware of this injection. But the nurse gave it IV. Now that is a sclerosant that is supposed to just close up your veins, thus stop the varices from bleeding out. It only has two indications. One for variceal bleed. The second for use by vascular surgeons to, women that don't like their veins in their legs and stuff like that. Either way, the idea is to sclerose the vein. And we gave it in the ICU. And I called the resident and said, and I called the attending and I called the pharmacist trying to figure out how did that error occur. And the most interesting part is that everybody's response to me was sorry. I'm like, I'm not worried about the sorry. I need to know why it happened. The most frightening part, which talks about the culture, is in a subsequent conversation with the GI attending, I heard it happened again. And that is why we need to change. Because if we just stop at this nurse did this wrong, then we did nothing to make sure it never happens again. The only way we can stop it from happening again is if we start asking these questions. So you know what? One of the things I've realized is this is the STEPS, which is one of the, it's one of those crude resource management tools put out by the HRQ for healthcare associations. I'm not going to talk about this because before we do this, they actually say figure out what your culture is and how likely you are to go with it. What I wanted to do is, we've used the description of a disease all this while. And the truth is, while I teach you diseases, in reality, how we really teach diseases is by doing a case study, right? We do disease studies. We say, this is your patient. So let's do this on a patient. So the last time I sent one of the residents one of my emails is I was in Coumadin Clinic. A woman came in. Dr. Anderson alerted me to the fact that she was dizzy. I examined her. She's got a heart rate of 38 and a blood pressure of 90. I look at her medications, and she's on both carvedilol and metoprolol, 2 beta blockers. No wonder the lady's blood pressure and heart rate are low. I asked her what happened, and she said, well, I was on metoprolol before I went to the hospital. I was discharged 3 days ago, and now they gave me this stuff. So I emailed the resident had reviewed it, the attending had said, I agree with the documentation. I sent them both an email. And of course, as I said, they both apologized. But if we're going to enter the culture, then we're going to ask why, right? So can we think of what kind of factors they were? Let's see, can you imagine a patient factor? Obviously, if the patient was more educated, she would have asked, right? Why are you giving me this medicine? Does it do the same thing? But again, we don't get to choose our patients. They are what they are. Can you guys think of a physician factor that would have led to this physician not doing the right job? So maybe they didn't look at the MedRec form. Maybe the MedRec form was filled out wrong, right? That is also possible, wrong by the nurse. Maybe the nurse hadn't actually documented that the patient was on metoprolol. What else? Actually, that was the resident that did it because the intern was off. So that means the resident was doing somebody else's job, right? So we had less staff. Oh, come on, write for me. So maybe we have less staff. It's an overburdened healthcare system, right? What else could have been the factor? Absolutely, and that's what we talk about the Swiss cheese phenomena, right? Ideally, even if the patient didn't check, even if the MedRec wasn't done, if the resident was in a busy fashion, the attending should have seen, the pharmacy, if nothing else, should have known, I'm dispensing this drug, the patient is on another drug, what happened here? But that is what the Swiss cheese phenomena is. There are latent failures in the system, and an active failure leads right through them. And we can do any of this, right? But at the end of the day, we can also go back, and as I said, we can do the Swiss cheese phenomena in this regard. Go back to a pen. Or we can do the culture of patient safety, which goes back into my asking, what could I have done to stop this from happening? So even if the resident messed up, and the pharmacy messed up, and the patient messed up, what else could we have done? So all of those things could have worked. We could have had better communication, right? We could have better team training. We could, if this was in the days before we had our pharmacy, so maybe if we had sent it to our pharmacy, they would have stopped us. They walk into our clinic all the time saying, hey, this doesn't make sense. Maybe we would have done that better. Any of those things would have worked, or simply speaking, I went to see this on my patient. So this is actually my own chart, and I tried to see what would happen if I ordered this on myself. Walmart probably has like 5 prescriptions for me right now. But I put this in. This is Epic. It's carvedilol and metoprolol. Now, this is an obvious error. Remember, the resident wasn't making this bad a mistake. The resident was just ordering one drug, probably never realized that the patient had metoprolol already listed as a home med. But even when I do this, this is what it tells me. So on one hand, the system has an intervention, it is warning me. It's warning me and saying, this is red, do not do this. But it gives me the ability to do any override. All I gotta do is say, clinician reviewed. And for as many studies as there are, they say that electronic health records save lives. There are as many studies that say physicians suffer from alarm fatigue. Every time that little thing is saying, are you sure, are you sure? And I'm just closing my eyes and beeping through them. So I could actually do that to myself, and it says previously signed, it's sent off 2 beta blockers. So if we are to really change something, the simplest thing to do would be for me to call, our IT guys, call Ricky and say, there is no situation where somebody will have to give 2 oral beta blockers together. Can't we make that a hard stop? Why are we waiting for there to be a perfect resident who will remember to check, who will not have alarm fatigue, who will check the home meds, for the perfect patient that will be confused? Why are we waiting for that perfectness? Why don't we just change it so that it won't go through? Why don't we just change that sclerosant so a nurse is not allowed to administer it? If that drug can only be used by a GI attending or fellow or a vascular surgeon, I have no business getting access to that drug. We should change it in a way that I don't get access to it. And that's how I thought it would help if we just kind of do a case. And with that, I'm ending, but I'm open to any questions. Looks like go ahead, Connor.
Can IT do that? Can Epic do that?
It's a good question. I don't know the answer. They can. Can IT do that? Can they put a hard block in there?
Yeah.
Yeah, when you called me earlier, I thought about it some more. So the one problem would be, so for example, many times, the example that I thought of after you and I got off the phone would be the patient that's in medicine clinic that can afford metoprolol, but we want to have carvedilol, that we want to get on a prescription drug a plan that's going to take 120 days to get it. And so, and we've seen that. I mean, we do a lot better now than we used to with the prescription, with the drug company plans. I mean, because we used to see this not uncommonly when they were bringing the medicines to us in clinic and we were handing it out. So.
That's true. So we go back to the drawing board and we go back and say, how do we find a solution for this? Could we have, if all of the the drug company meds are now being dispensed via pharmacy, am I right, Dr. Anderson? So we could have we could empower our pharmacists where once they obtain the drug company medicine, they could discontinue our old medicines. They're just ideas. It's when we enter into that culture that we bring up these questions and then we ask these questions. I don't know, James, you wanted to say something? Ken, sorry.
Yeah, I wanted to say a couple of things. The incident with sclerosant happened to occur while I was the attending. This occurred a few months ago in the emergency room. And the actions of the resident were excellent and very appropriate, actually. One thing that I do want to point out is that we heard this over and over again, that this happened yet a second time, and that is absolutely incorrect information that has been passed on. I heard it.
I apologize.
No, it's not your fault. I heard it again and then again, and we kept correcting it, and I think Dr. Morris heard it and corrected it. It was some sort of rumor that started that it happened another time, and it just kept going and was out of control. But that's not a major issue. The interesting thing about this is, I don't remember that we discussed this specifically, but the way this happened was very interesting because Dr. Hosseini Carroll and I were there. It was past midnight, and the resident was there and came up to us and asked us about this. And we immediately said no, and we went immediately to the room, in the emergency room there, and found that the nurse had already given this. What I did, I guess maybe I should be more proactive and should try and create more of an issue of things, but I went subsequently to the emergency room head physicians and told them about this. This is an issue, as far as I'm concerned, that happened for two reasons. Because of a system error in which the pharmacy says that this is an IV medication, and it is indeed given intravenously, but sometimes it's given paravaricil, not even in the varix. So it should really say for endoscopic use only. So that's a system error.
Exactly.
The other issue is, to me, very, very simple. And that is, and my wife is a nurse, and I asked her about this, and I've asked other nurses. As far as I'm concerned, a nurse should never, ever give a medication that they don't know the indication for. If they're not sure what the medication is for, and she was unsure, she should have questioned it and never given it. But within a matter of a minute or two from when the resident got asked the question, walked down to us, we walked back, she gave it.
True.
So these errors are preventable, and there are many others, and I agree with you. We are not proactive enough.
And maybe if we had a better reporting system, we would. And we'd call pharmacy and say, hey, change your labeling. Fix this right now. Well, we got a risk management person in the back with a question.
Well, actually, as of July, we have a new variant system. It's a much shorter form. It should take you less than 5 minutes, and you can fill it out anonymously. So hopefully we'll be getting more variances so we can fix the little process problems. So we are, anything like that, we would do an RCA and get everybody involved and hopefully find the flaws in the process and try to put something in order for it.
James, thank you for that.
One of the interesting things to why we're using that drug is also part of the systems problem that we have. There are two other drugs that are used in this situation. One of them is sodium morylate and ethanolamine, both of which are contained or are housed in our Pyxis or Diebold system and endoscopy. They are both on national shortage. Therefore, we have to go to the third line drug, which is not housed in our unit, has to come from pharmacy. Not only is it on national, it's also on a national shortage. And basically, this hospital is the only one in the city who can get the drugs. So we are basically the supplier for the city for that drug. And wherever a patient is who needs that drug, they come to this pharmacy to get the drug. It goes there. If it's not used, it is returned back to the pharmacy, and they can only get a very small amount of that drug.
Even more reason that we not waste it. And again, I wasn't suggesting that there was any error done on your part. What I was trying to point out was, if you look at the sharp end, you're like, oh, the nurse messed up. If you look at the broad end, then there are all of these things. Did we label it correctly? Did we educate everybody? This is a new drug. Have we located it properly in the diaballs? Should we have restricted access that only your iCard is going to work on it and not mine? Ricky, you were saying something.
I was going to say, I mean, so one of the things your topic didn't discuss is guidelines and protocols. And so, those, when you look at the airline industries and you look at other industries, they make decisions that you take in a situation and you treat it this way. I mean, I think in medicine we often push back. I mean, I've more than one time at different things at our institution have seen sort of people shoot down guidelines because they either don't like them or they say that it impairs education. So, I mean,
you will not find anybody that agrees with you more on that than me. And that is one of the things that the IOM said. They said safe and effective, which was look and see what has been shown to be effective. Stop trying to reinvent the wheel every time. If you know prolonged QT needs this, why are you doing a hard cath? Stick to the guidelines. But yes, we both are aware that it, and again, maybe we should do this, but then again, waiting for that perfect physician is probably not the smartest thing that we can do in trying to keep our patients safe. Anybody else?
If I could say one more thing, we're not trying to make excuses, but, and your points are excellently made. I mean, we need to be better at this. We need to be, my brother, who is an attorney, always talked to me and has an interest in medicine, always talked to me about checklists and how airlines use them, and we need to do that, you know. Something like your case that you described with the NG tube and the feeding. And that could fairly easily be solved if we just designed something that was on the tube that would clearly stay there, and if it changed position, that would be an automatic indicator that was understood by everybody. That
True.
When you see that, you stop, and here's a process that you follow, including the X-ray and everything else. So
And
I agree.
That is where the healthcare industry
We're on your
needs to go.
side. We're on your side for sure.
Well, we're all on the patient's side, and that's why this is so interesting, is like, if you're all on the patient's side, why is it taking us so long? And I think the answer is that culture. While we know what is correct in our hearts and minds to do, we are too deeply entrenched in our culture. So it's going to require a culture shift, and if I could get you guys to start a conversation today, then I've been successful. So thanks for coming.